Hey everyone, it's Dr. Namani and Dr. Louie here, back again with the Athlete Spine. And today we are excited to have as a guest with us Dr. Peter Derman, who is a dear colleague and friend of ours, who's a minimally invasive and endoscopic spine surgeon at Texas Back Institute. Hey, Dr. Derman, how are you?
Great to see you guys. Thanks for having me.
It's great to have you. So today, the topic that we're going to touch on is lumbar disc herniations. And this has been in the news recently with Will Zalatoris, who's ninth in the world golf rankings and recently won the FedEx St. Jude Championship, but had to pull out of the BMW Championship due to severe back pain. And this was found to be due to 2 lumbar disc herniations. And this is a common problem among golfers and CrossFit athletes and really athletes of all types. And so we have Dr. Derman here with us today to kind of discuss this topic some more.
Yeah, exactly.
Yeah, we thought this would be a timely topic because a lot of people have been reaching out to us, especially the CrossFitters who are asking us about lumbar disc herniations because they hear about it all the time. So, we've got one of the experts here, and then I think we'll talk about both sets of athletes and what exactly this disc herniation is. So, Dr. Derman, when people say disc herniation, what is that?
Yeah, so let's start with what is disc. So the lumbar spine is the low back. And the spine is made up of bones alternating with what we call discs, which are kind of cushions. And I have a model here just to give you an idea of what that looks like. So this is a model of a low back. This would be the front. This would be the back. And you can see that there's these bones in the front. These are called the vertebral bodies. And between each one of them is this rubbery substance called a disc. And what a disc herniation is sometimes part of the disc, usually this inner, more gelatinous part, can push out through this outer rind and push on the nerves behind it. And that can cause back pain. But when it presses on these nerves, it can also cause sciatica or pain, numbness, tingling, weakness, shooting down the legs.
Yeah, and Will Zalatoris, it sounds like he's been struggling with back pain. We don't know all the details of what's going on with him, but like you said, the presentation of someone with lumbar disc herniation can be pretty variable, right? They can present with severe back pain alone. They can present with back and leg pain, sometimes even just leg pain. And then you can sometimes get some more scary symptoms, such as weakness in the legs, numbness, tingling, or even in really, really severe cases where someone's bowel and bladder stop working properly. And those are the scary emergencies. But usually, lumbar disc herniations present with some combination of back and leg pain.
Yeah, and I think we see this all the time. And, if we break everything down, the most common presentation is some sort of combination of pain, whether it be in the back or the legs. And it sort of just can be annoying at times. And, and it can happen to any type of athlete. We're focusing on the CrossFitters and the golfers today. Are there specific positions or activities that put athletes at greater risk of having a disc herniation?
Anything that involves bending and lifting and twisting, which really golf is all of those things. But a lot of activities do. And so, Olympic lifting is a big one of them. So that's a big part of CrossFit. That doesn't mean you should never Olympic lift. But, the second that you get fatigued and lose your form, you put these lumbar discs at more risk because they're carrying more load. But every sport and every activity, a lot of my patients, they're not necessarily even playing sports. Maybe they just kind of develop this, or maybe they just bent down to pick something up and they start to develop these symptoms. So it can really happen at any time.
Yeah, so tell us what's going on, right? You talked about it on your model that, hey, you can have this gelatinous material. Dr. Namani always talks about the jelly filling kind of popping out of the jelly donut. What exactly is happening, and why are there symptoms that go down the legs?
Yeah, so what's going on is the disc is made up of an outer kind of rind, which is the outer part of Dr. Ramani's donut, and then the inner gelatinous jelly substance, which is the jelly filling. And so in some people, they get some deterioration there, or they've had some sort of trauma, and that outer rind kind of breaks down. And some of that inner material can either kind of bulge out or come completely out. And right behind that area are those nerves. And those are the nerves that go down your legs. And so when that happens, one, it can create back pain, and two, it can push on those nerves, and it also releases all these inflammatory chemicals that then irritate the nerve. So there's kind of two mechanisms by which it tortures people.
So these are really common injuries. You know, there are reports all the time of athletes suffering with back pain and even with leg pain, and reports of people having herniated discs. And I know many of us, obviously us as spine surgeons, see lots of these patients, but I know many of my non-medical friends also know people who have had disc herniations in their back. How do you treat these?
Well, fortunately, the vast majority of these get better without surgery. So just because the symptoms can be very dramatic at first doesn't mean that all hope is lost and that these patients, these athletes are going to need an operation or something like that. About 80% of lumbar disc herniations will get better without an operation. And so I like to start with the more conservative stuff, barring any of the bladder and bowel things or severe weakness. That's a different category. But what we're going to talk about here is kind of the run-of-the-mill, not dangerous disc herniation. And I like to start with some sort of therapy, physical therapy, something like that. Often an anti-inflammatory medication can be helpful to bring down that inflammation we were talking about. And if that doesn't give the relief that the patient needs, or if they can't tolerate that because they're in too much pain, a reasonable next step is something called an epidural steroid injection. So when people talk about having injections for their back, there's a variety of different kinds. But in the setting of a lumbar disc replacement, an epidural steroid injection is the most likely thing to be used. And what that is placing steroid medication, which is a very strong anti-inflammatory, right there around the nerve. And that can calm down any inflammation, which can help give that nerve a little bit of relief and hopefully buy enough time for the body to either get used to the presence of that disc herniation, and then maybe it doesn't even matter that it's there, or in some cases, the body will actually absorb those disc herniations and they go away completely.
And it's important to realize that at the end of the day, based on our literature and the research we've done in our field extensively, 80 to 85% of disc herniations never require surgery, right? And, a lot of these interventions that Dr. Derman has brought up doesn't necessarily cause the disc to just go back in, but our bodies do a good job of trying to reabsorb the disc over time. And a lot of these interventions help try to provide comfort or even decrease the inflammation while our body's doing that job. But we know there's a subset of patients where it just doesn't get better. And, we talk about surgery, and what does that surgery look like?
Yeah, so at a high level, surgery for a lumbar disc herniation and associated sciatica or radiculopathy is a discectomy surgery. So disc means disc and ectomy means remove. And so what we're doing in these surgeries is removing the piece of the disc that has come out and is pressing on the nerves, basically. We don't remove the whole disc. Hopefully the patient has that disc for the rest of their life. And we're very careful not to go mucking around in the good stuff, in the good part of the disc, but you just want to basically shave down the part that's come out. There's no way to push it back in there and get it to stay. And it's not doing the patient any good anymore anyway. So we basically just remove the part that's come out. The most common way this is done is called a microdiscectomy. There's a variety of different kind of nuances to how it can be done, either a traditional open incision, or there are these tubular retractors using either a microscope or what we call surgical loops. What my passion is endoscopic discectomy. So this is kind of, and they clean it out. And so you can actually scope the spine too. And that's what endoscopy is. I make a little incision about this big, and I have a camera that goes down, and I can watch the whole thing on a big screen and clean out around the nerve. And the beauty there is not just the tiny incision, although I pride myself on my tiny incisions, but it's also the lack of damage to muscles and tendons and ligaments and joints that surround the spine. And that allows patients to bounce back really amazingly quickly. I do a lot of these, and it never ceases to amaze me, just how quickly patients bounce back. They're out of the hospital within a couple hours. Oftentimes their sciatica, their leg pain is dramatically better, if not completely gone, as soon as I finish the surgery. They usually don't take anything in the way of pain medications, maybe some Tylenol, often nothing. And oftentimes they're back at work within a day or two and can return to low impact activities really immediately as soon as they feel comfortable doing so.
Yeah, I mean, it's really amazing. This is I think a paradigm shift that's happened over the last, decade or so. That we have, as spine surgeons, evolved to doing more and more minimally invasive operations. And Dr. Derman, you've kind of really been a thought leader in the field of endoscopic spine surgery, and he's helped to develop, some of the instrumentation and techniques and taught other surgeons about how to do this effectively. And so, and I think with lumbar disc herniations, it's such a common pathology, and finding ways to treat it in as minimally invasive a fashion as possible to get people back to activity as quickly as they can is really, really important.
So sort of the final question and sort of the $1 million question for a lot of these athletes sometimes is, when can they go back to play?
When they can go back. So the beauty of these minimally invasive techniques is you so quickly. However, there is a caveat there, which is that we still have to give the outside of the disc enough time to heal the defect through which the disc herniated in the first place. And so the concern until that happens is what we call reherniation. So more of this disc material coming out. And so even though I let my patients and my athletes go back to, walking, elliptical, stationary bike as soon as they feel comfortable doing so, oftentimes the same or the next day, we do have to avoid heavy bending, heavy lifting, heavy twisting for about 6 weeks after surgery is what we do. Because what we don't want is more disc material to come out. Those bending, lifting, twisting activities, as we talked about earlier, that's what puts more pressure on the disc in the first place. And so this disc is compromised because of the herniation, and we want to give it every chance to heal. So for 6 weeks, we avoid those kind of more strenuous activities. But then after 6 weeks, I cut people loose to return to all of the activities that they want to do. Obviously, you're going to want to do that in a mature, kind of gradual fashion, but patients can ramp up pretty darn quickly. So I guess the answer is for 6 weeks, you're going to want to kind of hold back from any sort of competitive or high level physical activity, but that doesn't mean you're like a lump on a log or anything like that. And very rapidly, these high level athletes can get back to what they want to do after that period of time is over.
Yeah, and since we're kind of started this conversation talking about the golfing world, we don't have to look any further than Tiger Woods to see that unfortunately these disc herniations can happen again and again at the same level in certain people. I think we don't quite fully understand what puts some people at risk for these reherniations compared to some other athletes, but usually for most folks, if they have this problem, they get it treated, whether that's non-surgically or surgically, and they can get back to doing all the things they like to do, and it doesn't cause them any further problems.
That's right.
Yeah. I mean, I think this has been a wonderful discussion, and it's sort of fun to think about the injuries and the problems that anyone can experience, and it's not just these high level athletes. And so Dr. Derman, thank you again so much for joining us today. Again, this is Dr. Peter Derman. He's a minimally invasive and endoscopic spine surgeon at Texas Back Institute. I really enjoyed talking to you today.
Yeah, it's always a pleasure to hang out with you guys.
It's great. It's great seeing you again, man. So until next time, be sure to like and subscribe and follow us on Instagram at The Athlete Spine. And also be sure to check out Dr. Peter Derman's page at Peter Derman MD.
Yes, sir.
All right, see you later, everyone.
Take care. Bye-bye.
See you guys.